and we have a number of very esteemed faculty here today, so I'll just let everybody go ahead and introduce themselves. We could start with you, Dr. MacArthur. It's going to be hard for you to reach that mic.
This is a very big panel. So my name is Heather MacArthur. I'm the clinical director of breast cancer at UT Southwestern in Dallas and the Komen Distinguished Chair of Clinical Breast Cancer Research. Thank you.
Hi, I'm Mary Cianfrocca. I think you met me this morning. For the purposes of this panel, I'm a breast medical oncologist at City of Hope. I'm switching hats again.
Hi, Joyce O'Shaughnessy, breast medical oncologist, Baylor in Dallas, Tex Oncology.
I'm Rachel Lehman. I'm breast medical oncologist at MD Anderson.
Matthew Ellis, my most recent academic job in breast cancer oncology was at the Lester Institute's Breast Center at Baylor College of Medicine. Then I helped AstraZeneca develop drugs for a little bit, and now I'm developing breast cancer tests, so you can talk about that.
Mark Pegram, medical oncology, Stanford University in Palo Alto, California, where I'm a medical director of the Clinical Translational Research Unit and Associate Dean for Clinical Research Quality.
Tanya Gupta, breast medical oncologist and clinical assistant professor at Stanford.
Chirag Shah, outnumbered radiation oncologist and co-director of the breast program at the Cleveland Clinic.
Frank Piccini, radiation oncologist in Michigan.
Tom Buckles, I'm a breast cancer radiation oncologist in San Diego.
Thank you. Hello, everybody. My name is Lina Todorova. I'm a third-year Hem-Onc fellow at University of Tennessee Health Science Center. And this is a case that one of my attendings gave me. I did not personally see this patient, so try to chart me as much as I can. Just an overview. This is a 64-year-old African-American postmenopausal female with history of a stage 1A lobular carcinoma of the right breast. It was ER positive, HER2 low, status post lumpectomy, radiation to the breast, and was started on anastrozole. Unfortunately, this was back in 2012. And then, unfortunately, this patient was found to have recurrent disease 5 years later with bony mets. Basically, she had progressed from multiple lines of therapy after she was started on endocrine therapy plus CDK4 inhibitors, and she was on exemestane, everolimus after that, then capecitabine, then trastuzumab, deruxtecan, and now again found to have progression. And the question to BNL is, how would you address this case if this patient wants to continue treatment? And if we could switch to the next slide so I can give you a little bit more detail about the patient. So as I said, this patient is 64 years old, postmenopausal, presented in 2012 with a right breast lump. Her pregnancy status was ECOG-1. And she did have history of hypertension, hyperlipidemia, type 2 diabetes, no alcohol, tobacco, drug use. She did have 6 daughters and a mother with breast cancer, diabetes. And this is again a summary of her history. Initially presented in 2012 with stage 1A, urine positive. Oncotype was low, so she was not given chemotherapy in the adjuvant setting. So she underwent lumpectomy and radiation to the breast and was just started on anastrozole. And as you can see, unfortunately, she had about 5 years in 2017. Unfortunately, she was found to have bony mets. Again, the biopsy of the bony mets was confirmed. This is metastatic breast cancer that was ER positive at 100%. PR was negative. HER2 was equivocal. So we did a FISH, which showed HER2 low disease. She did undergo genetic testing as well, and interestingly, was found to have BLM mutation. I was looking it up. It's Down syndrome, autosomal recessive rare disease that can increase a patient's risk for breast cancer, but this patient was heterozygous. And was then started on fulvestrant and palbociclib. Do you want me to stop here? Okay. Yeah. So first of all, could the panel talk a little bit about the biopsy results? We see that she's ER positive 100%, but PR negative, poorly differentiated. How are you kind of thinking about the biology of this tumor?
No, I only was a sensitivity. But with this, I'm a bit unclear. Is this a somatic mutation or is it a germline?
Germline.
You know, so that is an inheritance there, whereas but it's heterozygous, right? It's the BLM which took like a sacrosantolan and once in puberty on the menses children, so she's heterozygous. So the interesting thing is with tumors in any way lost in the secondary needle, do we know?
Has not, right? Because brain lens line a little later on that she had liquid biopsy where we don't see any kind of any BLM mutation or somatic
deletions. Right. It can't, because it's what contaminated DNA from the normal blood means that you can't detect deletion, though you white mutations. That's why the problems with medicine. So catabolic tumulent and saying it wasn't. The question is, does it matter? That's why I'm looking it up here.
So
I just want to
is anyone familiar with Bloom syndrome and BLM mutations? So a couple additional things that I saw about BLM mutations. There was a study of about 600 Polish patients that were heterozygous for BLM. There was no increased breast cancer risk compared to the cases that posed. So I don't think the heterozygous, but they did mention in their paper that there have been a lot of different studies on these conflicting results. So I think there is some controversy about whether a heterozygous BLM mutation caused breast cancer. Does anybody kind of have a sense that they think the BLM mutation is causing this patient's breast cancer?
Oh, just one thing, so it's just heterozygous. The tumor dumps the second allele, so it's homozygous in the tumor, and then there's heterozygous in the demon, in the germline. BLM gidipate divisions enter architect dishes to improve outcomes called at Allen. These others. Laparate resistant forms meaning a lot less. Why inhibiting some of in combination with it. So the bottom line is, in that there's rare things, but I think outside the box, it could end up in a case room. Because you manage to, get hold of a laparate or let to drug for her. And you're not surprised. I mean, clearly the lady's in a lot of trouble and needs a lot of thought. But I'm thinking, maybe we should talk about it. Lightly pathogenic area is interesting. But yes, it's not absolutely pathogenic because it's not there and it does speed the detection into the
Definitely.
The bottom line is I would probably choose that as a thought. Otherwise, we're all talking about our fading, but our favorite kind, their patients first. It could be something mainstream-based.
Does the fact that she's 64 at diagnosis, we can change how you think about that BLM mutation, whether it's
all about I had patients with BRCA mutation because I finished in COVID. I did range there, so when needs a red events, there are events, always
Another mutation that's enriched in lobulars is HER2 kinase domain mutations. I think Matt and I are co-authors on some of the Imaz papers showing about a 1.6% incidence in breast cancer not otherwise specified in a clinical trial that we put together. But in the lobulars, about 8%, and that difference was statistically significant. It would be interesting to see what the HER2 kinase domain looks like in this case from a DNA sequence point of view. The other thing, though, that's a little bit disturbing is it started out at stage 1A lobular. I assume that means pure lobular, but then the metastasis is poorly differentiated, so it clearly seems that this histology has changed for the worse. So, this patient must have other hits that are brought to bear for this particular carcinoma, and it may not behave like a pure lobular anymore. But I would still look for the antikinase implementation.
And just for all the fellows, when we're talking about HER2 mutations, it is different than a HER2 overexpression.
On that, you see, there's a coordinate pathology, and it's in a 5-year interval. You definitely have to repeat breast imaging and look for a second breast primary. That could be a different source to be really good at it.
I was thinking, there are companies developing HER2 mutant mutation drugs that are selective for mutants, overcoming some of the toxicity problems and short PFS with Enhertu, we saw in our original study. So let's hope those drugs can meet patients. But I guess this patient probably doesn't yet. Well, I see you did the NGS again, so.
But also just from like a standard practice point of view, I hope that the CT scan and the bone scan were done in response to some symptoms, just to underscore again that routine imaging in the adjuvant setting is not an evidence-based strategy. So hopefully that would.
Yes, week long that to be.
So it's referred sitting on. And the importance of doing the biopsy to confirm the diagnosis, and also this woman recurred just over 5 years, I think, from her original diagnosis, and that this 5-year graduation idea that a lot of our patients still have, that some sort of finding cutoff that they're in their zone is very misleading, and we still work a lot to so the hazard ratios are highest, right, for ER-positive disease within the first 5 years, but that deal extends potentially for decades when victims have recurrences after 5 years. So, birth fires, ongoing vigilance.
Excellent thoughts, thank you. So moving on, in 2021, there was another CT chest adenomas that showed progression of disease. This patient was then started on exemestane and everolimus. Unfortunately, only a year later, we do see another bone scan being done that did show slight worsening at TA. NGS was done, and this time we see on liquid biopsy PIK3CA mutation specific to TH147R variant of and then a variant of uncertain significance in PTCH1 and RET. PL testing was negative, and CT chest abdomen and pelvis did show stable bone disease without other concerning lesions.
That's BKL1 testing done because there was a loss of receptors. Because we typically do that in ER-positive, and so there's.
I'm not sure exactly what PL, that was my thoughts exactly, because I was going to be negative, what CPS score is.
Was she actually symptomatic of TA?
As I said, I have not seen this patient, so I am not sure at the time. I did not see it recorded.
A year or exemestane and everolimus is pretty good. She's tolerating it. I don't think there's enough evidence she's progressing. I'd keep her on.
She's gotten a year on a Blair regimen if she's tolerating it well. A really key point for patients is that if we change therapies too rapidly, we're going to run out of therapies. And for slight worsening at one place, often would just watch it and continue the same therapy.
Now, in that case, would any of the radiation oncologists have any interest in TA?
Definitely would consider radiating TA, possibly just one fraction or even a stereotactic.
Yes, a couple points. One, if she's symptomatic, I would always get an MRI, make sure there's no orbit pressure or anything, especially if she's high performance status, because there I want some type of surgical intervention potential if she's high pump today. There was actually a paper, I got to keep up with all of you, there was a paper that came out last week in Cancer that actually showed for vertebral metastasis, the dose escalation did improve pain response. So there is some thoughts to give you a little bit of a higher dose, but it was only in 6 months, but it did show it compared to conventional fractionation. It was a prospective randomized trial from Unlike Your Own.
That's the bit of no disability and no increase in tumor markers of that and was still radiating. What is possible?
I mean, I think the idea that radiation will change disease and metastatic oligo progression is kind of all like known. We have BR002, we have curve. I think the idea of ablative therapy in that situation is probably not really data driven to say there's a survival advantage. So I probably would push the issue of radiation there in that situation.
I mean, it's weight bearing, so it really depends on the degree of cortical, erosion, thinning. So you'd have to see the radiograph to make that determination, probably. Slight worsening, though, is not RECIST criteria for progression, so I think I would play through with the exemestane for sure.
Also, you have to wonder, it doesn't mention, or at least I didn't see that she's on bisphosphonate, or, but, slight worsening at T8 could also be a compression fracture.
She has been responsible into those.
And it takes a lot of care to evaluate bone disease on scans. And I think a message for the fellows is that you have to be really careful calling progression in bone-only disease because a lot of times it's not. And you have to look at everything. The symptoms, is it progressing somewhere else? It's really it's a thoughtful decision. It's not a simple glance at the report, she's progressing.
Would anybody like to speak about the liquid biopsy results, about this particular PIK3CA mutation?
It's the most common.
Yeah.
And all 40% of breast cancers will have it, 35-40%, and it's there from the beginning as part of the pathogenesis of it. So not too surprising to see. It's interesting that she's been on, a downstream inhibitor of PIK3CA, mTOR. So whether that has helped a little bit of clonal expansion to in the metastatic setting to become resistant to everolimus is a possibility, but it certainly is a nice target to think about going after at this point. So I think we had already mentioned probably most of us would do with pivosertib at this point because of the better tolerability than alisertib with fulvestrant.
Can I ask my medical oncology colleague if they follow the cyclin E story, the whole molecular weight cyclin E, and I was thinking about these two very favorable ER-positive lymph node negative patients who have recurred. And these molecular weight isoforms, which are post-translational modifications, are amazingly prognostic, right? There's a New England Journal article showing like 100% survival versus 0% survival. And does anybody follow that ever, or any thoughts on cyclin E biology? That's Matt. He's like the big cyclin Matt.
It's kind of not there yet. I think it comes back to the whole issue of the antagonist and G1S. Because, the hormone-dependent diseases, cyclin D, are dependent, right? Both if you get a partially broken G1S checkpoint, it becomes cyclin E dependent. They do behave more aggressively than everolimus assist to stimulants.
But hopefully CDK2 inhibitors will be a therapeutic option for those patients as well. But I think it's a very important marker of resistance. I think it really shows bad biology in general, other contexts as well. But I think CDK2, 4, 6 or something are maybe a nice option for this patient status relevant.
And who has one of those? Is Pfizer working on that?
I think I don't please.
Okay. So the patient in July of 2022 to August 2023, she started on, or she's been on capecitabine. A good response per chart review, tumor marker results. However, in August of 2023, she did have a CT chest abdomen and pelvis to show a significant decrease in size of the two largest hepatic mets, stable bone mets, and no other metastatic disease. That's when the patient was started on trastuzumab, deruxtecan with good tolerance. And then in February of 2024, another scan did show progression of disease. So the question to the panel is, what would be the next line of therapy in your opinions?
In performance stands.
I believe her performance has remained around 1.
It's okay to go back to endocrine therapy if her performance status and organ function is good enough, and she hasn't had the PIK-BCA target yet, so that's still an option for her.
It is fluid. But yes. And she's been through everything that a woman thinks is conventional.
She hasn't had alpelisib or capecitabine.
So no one does this except me, which is physiologic estradiol therapy. It's remarkably effective in some patients. It works better the older the patient is, and more estrogen receptor rich they are. Well, in my JAWA oncology paper, it was like 6 milligrams versus 30. There was about 30 patients in each arm. But the response rate was much better. Obviously, the response rate about the same, and the drug is much better tolerated at 6 milligrams, no surprise in there. But 30 was actually the package insert. But it's worth a try. If you go and check uterus, you have to keep an eye on uterine bleeding, which you are tomorrow in terms of that's. If they get through, and if they have a flare, otherwise they have a lot of pain within 2 or 3 days, it's working. If you just stop the estradiol, let it all settle down and restart it. Yes, we had the responses, both responses. And some of the responses were like 10, 12, 15 months in patients who look like this.
Matt, like I, were victims of learning the 9 months of endocrine therapy when we were fellows. So, along with high-dose estradiol, you can think about aminoglutathione and manganese, all kinds of good things. Definitely not aminoglutathione. Definitely not aminoglutathione, forget that.
I always worried about recurrent testing as another thing that one could play with. So in other words, you know, this sort of old trusty medical oncologists like me would try. You go back to an AR, yes, but my experience, and then there is, it doesn't work, right? But there are these extreme responses to estradiol therapy. 6 programs start high dose for some intermediate dose. There was a bunch of docs in England who tried to go to 2 milligrams, and I don't think it was effective. That was like Tony Howell's son, whoever was in the company, what was his name, Sasha Howell. But, yeah, but anyway, so, what the thought? Now, she got into DBT, both in North, but this is mobile, all the rest of it. You can enter that.
So would that be your next? Would that be your patient was in your clinic? Would that be what you do
I'd
next?
seriously consider it. Yeah. If there's 100% ER positive, and she had like slow progressive disease, the responders open.
What about the poorly differentiated? Is that steering you away at all? She didn't really behave like a poorly, you know, like
I'm not sure I believe that as much.
Yeah.
I'd go back and look at that a bit carefully. Well, maybe it just happened to be a clone that was biopsied. This is a multi-clonal disease. It could be the rest as they become much more developed disease.
Would anybody use this thing called taxanes and agromycin before she passes away?
Well, there are ADCs that have beat those in randomized phase 3 trials. Tanya and I were just talking about, tropic so
And there are a lot of other biologic options too. So I would probably repeat a biopsy at this point to a liver biopsy to better understand biologically what's happening. But we talked about HER2 mutations in invasive lobular cancer. Oftentimes I detect an androgen receptor mutation to Matt's point about endocrine manipulations, and I treat those patients. I have several patients in my practice right now who are on meclutamide because they have androgen receptor positive metastatic lobular cancer. Palbociclib as monotherapy, especially in those who have liver metastasis like this patient, would be something else that I would try, especially given the interval since last CDK exposure. So I think there are a lot of actually really great options for this patient group.
I have a question, which is sacituzumab, deruxtecan, or Elizabeth in this patient, for example, as around PIK3CA, but then I guess the next after TDX. And how to make that, how do you make those decisions?
This is really controversial because we don't have data on ADC after ADC. My preference is to switch it up a little bit. If you're gonna go that approach, do something different. If you're gonna, and then consider trying it again, just because those two drugs are so similar in so many ways. But also, I agree with Pat saying that I think mixing it up and maybe trying to go back to endocrine therapy before trying something more chemo, like I consider ADC chemo.
And in this particular case, if memory serves, I think she only had about 5 months on TDXT. And so I would have some hesitancy about going to SASI at this point, another topoisomerase 1 inhibitor. I agree with what others have said. I would be inclined to pursue the PIK3CA mutation here and use capecitabine with Faslodex, with fulvestrant, even though she's received an mTOR inhibitor in the past, and perfectly fine to go back to endocrine therapy.
New prospect in an ADCC is data.
No prospective, but there were 3 papers of kind of chart review level data presented at San Antonio. One was from France, one was from Boston, one was from UCSF. They all showed the same story. They really did. ADC 1 always beats ADC 2, no matter which order you give them in. And in the French study, they did ADC followed by ADC versus ADC followed by an intervening treatment of some sort like chemo, and then ADC, to your point, trying to space the distance between ADCs. And there was no difference between those two either that was statistically significant. Now, all these are really small numbers of patients. Retrospective chart reviews, so you can't hang your hat on any of this with statistics, but the story was compelling because all 3 showed that ADC1 always beats ADC2, with rare exceptions with the topo1 gene alteration. Sometimes they would get responses with the second ADC in that instance.
I would also say that these 2 ADCs, because there's a lot of other ADCs with different payloads that may work, but with the payloads being so similar, I just really don't think it's a great strategy, and I haven't used it much.
And I think prospective data is coming there. Shameless plug, my mentor, Dr. Matani, is opening an investigator-initiated trial, series trial, to get us some prospective data on this subject. So I think in the interest of time, we're going to move on to case 3. Thank you so much.